Okay, so my name is Jarod Wong, a pediatric endocrinologist based in Glasgow, and over the last almost 7-8 years, I've had lots of experiences in Duchenne muscular dystrophy, particularly the growth, bone, and endocrine side effects. But over the last 20 years, my own clinical research interest is in the area of childhood chronic disease and how it impacts these kind of outcomes. What are they? What's the distortion? It's probably... Wait, hang on. I might just have to put this here. Okay, I realize I'm between you, all of us, and lunch, so I thought rather than giving you lots of data, I'm going to tell you a story of this boy called Leon. Leon was diagnosed with Duchenne muscular dystrophy about the age of 5.5 due to some muscle symptoms, which I guess is sometime may even predate a little bit earlier. And after some discussion and getting in touch with the neuromuscular team, prednisolone was started in a daily regimen around the age 6, and he seemed to have some improvement in his muscle outcome, which seems to be the case. The neuromuscular clinician was aware of the 2018 international standards of care and knows that bones are affected even very early and with a short period of steroids. And the 2018 international standards of care suggest that there needs to be these regular lateral spine imaging to try to look for spine fractures or vertebral fractures early. And Leon has been having these annual spine imaging. Around the age of 8, he is shorter than his peers, but is reasonably okay with that at that time. And you can already see there are some, it's probably not coming up, and I don't know whether I can move. I probably can't move, I can. You can probably see that there are some, this little vertebra there, which should all be rectangle in shape, is showing that it's a little bit squished at the front, okay? It's a side-on view of these x-rays. And that classifies as mild vertebral fractures. He has no pain, he's happy, and the international standards of care currently states that if you've got mild vertebral fractures and there's no pain, you don't need any treatment. So the neuromuscular clinician was doing what's recommended as part of care. But a couple of years later, and as part of, around about the time when he came to clinic, he's been getting some sort of more new onset back pain. It's getting worse. It was at a time when he was coming to clinic, and he was due his annual spine imaging anyway. And you can see that there are multiple of these vertebrae which are just quite squished, okay? So a couple of years before, there was this one mild vertebral fracture, and there are now multiple fractures, and a lot of them in the more moderate or severe category, and he has got back pain. So the international standards of care currently recommends that if you've got vertebral fracture of any grade, mild, moderate, or severe, and there's a classification symptom method which I'll show you a little bit in later on. So any fracture grade, if there's back pain, we recommend this treatment with osteoporosis treatment called bisphosphonate. But if we find sort of more moderate grade or severe grade of fractures in this back, even without back pain, we should actually start treatment with bisphosphonate. So off Leon goes to see an endocrinologist like myself, who then recommends treatment with bisphosphonate infusion, which some of you might have heard about. And he received that. But then Leon, the family, was asking the neuromuscular clinician to say that, hey, I've heard so many boys with Duchenne seem to sustain fractures, particularly of the back and also of the long bones. And why did I not receive treatment when it was milder? Could it have prevented this back pain and this thing from spiraling? So what do I think? So here again, I'm just listing the current 2018 international standards of care. It does recommend regular lateral spine imaging, so that should be done, and also the threshold for starting with bisphosphonate. So just to give you an idea again, I guess I've used these two spine images early on for Leon. You can see that on the left, most far left, or that bit, you can see nice rectangle vertebra on the side on, so that's all entirely normal. And on this side, you can see on a larger projection, you can see there's lots of vertebrae which are just not normal shape, okay, quite squished. Can everybody see that? Yeah. And on the left, on the middle, sorry, there is just like one or two which is just marginally squished and on the front, so that's like mild, okay? Quite a few of these are quite what we call severe category, and some of these are moderate category. So that's just to give you an idea of what these pictures look like and what have we been doing in Glasgow. So the 2018 Standards of Care recommends spine monitoring. We've been doing it since about 2015, so we've had about 7 years of experience. All our boys get it about once a year. We've been starting intravenous bisphosphonate initially prior to the 2018 Standards of Care, around about the 216 to 218, only if there's at least some back pain. And we then moved to largely following the 2018 Standards of Care. So if there's mild fractures without back pain, we tend not to treat and we tend to monitor and wait for moderate grade. Here, I just want to share with you some of our experience of the monitoring and also treatment. And it just has helped me reflect on how maybe care needs to be changed in the future. So what I tell you is not current standards of care yet, but it may just be a way to move forward to manage some of these problems more proactively. So over the 2016 to 2021, I've treated about close to 20 boys with Duchenne muscular dystrophy and IV bisphosphonate. We're a clinic that effectively have only been using daily steroids, at least for the last 7 years. We're a relatively small clinic, about 40 to 50 patients. About half of my clinic actually have vertebral fractures, so that just gives you an idea of how common it is. So out of the 19 boys that I've treated, 17 have vertebral fractures, and they started treatment around the 12 and a half, but some quite early, age about 7. Boy took a bit longer, although we've identified the fracture. It took him a while to come around to coming for treatment. And all are on daily steroids. We have a handful of boys on 10 days on 10 days of steroids, and none of them have vertebral fractures. It's certainly less common based on published literature. Now, because of what we have been doing, in a sense, following the current international standards of care and pre-2018, we've been waiting for some back pain. A larger proportion of our cohort who are treated with vertebral fractures do have some back pain, and there are some with no back pain. So there are 11 boys out of the 17 that we've treated did have mild vertebral fractures without back pain identified through this annual spine imaging. And remember, these are boys which the 2018 Standards of Care say that we should not treat with bisphosphonate medicines, right? You follow me? With follow-up, all of them seem to have deterioration of the spine. So on those graphs, so here's again the graph that you can see. So that basically shows that these are the normal, these are mildly affected vertebra, these are moderate, and there's a more severe category, and that's how we grade vertebral fractures. Okay, so all these boys only had mild vertebral fractures at the first time we identified them, and they're all progressed. So about 20%, so bearing in mind, you've got the numbers there, the numbers are small, but it's really just to highlight a point. About 20% showed that those who had the mild vertebral fracture, those backbones which did have mild vertebral fracture became either moderate or severe. All of them seem to have new mild vertebral fractures, and about over half of them, in fact, actually, the spine at baseline or the first scan was entirely normal, just developed a fracture which was moderate or severe, okay? So really, it shows quite a lot of our boys showed deterioration or progression of these fractures without treatment. This is something we call the vertebral fracture cascade. But what's more important is also looking at back pain. And out of the 11, almost all of them developed back pain. And we use a more comprehensive way of classifying pain using this sort of like smiley face of what, in fact, actually, it might be one of my old relatives. It's called the Wong-Baker score, which a lot of you probably would have had experience in different parts of pain assessment in pediatrics. But we also try to get them to localize the back pain. And most of all of them, 10 out of 11, actually said they actually had back pain. And in fact, the one that we couldn't actually capture back pain was basically a boy who was actually very severely affected and is non-verbal, so couldn't really quite tell us or classify. And the other thing as well is that 6 out of 10, 60% when I actually examined the spine, when I actually poked on the spine, they were tender and palpation. So what does it tell you? If I follow the current 2018 standards of care, do not treat mild vertebral fractures without back pain. With follow-up, and most of them were over 1 or 2 years, it will seem to progress, and quite a few of them will seem to develop back pain. So These are some of the examples of the boys in there, and I'm just going to give you an idea. So look at this. I can't actually, if I just use where's the point, and the pointer might be better, isn't it? So if you can see, here's the pointer. Not sure I can use that. But you can see that some of them, we can see that there's just marked deterioration of this vertebra, which was sort of quite square or just mildly squished, which just became very affected. And similarly in this kind of boy. And you can see that these are all roughly the same. This boy stayed a year and a bit, remains ambulant. Steroid dose stayed about the same. So what are my thoughts? So here's what I think. I think boys with DMD, with mild vertebral fractures, without back pain, if you don't treat them, or who were untreated, will show progression of these fractures, and quite a lot of them will develop back pain with time. And I think what's quite appropriate, and is already happening in some clinics, is that if you find mild fractures, this should be considered for treatment. And you might find that even though the standards of care says that only moderate or severe fractures are treated, you might find that some clinics are starting to have that discussion. But fractures are very common. We know that about 3 years of steroid treatment, especially daily steroid treatment, probably about 25–30% will have fractures. Michela mentioned some longer-term studies, which showed that probably about 75% eventually will develop fractures, both long bone and spine. So patients often ask us, like, why are we waiting till things happen and then initiate treatment? And I think maybe there is a case to think about initiating treatment in some of the boys with DMD at the highest risk for fractures and intervening with treatment, just like what's been happening perhaps with like cardiac protection, for instance. How we do it, we need a little bit more evidence. We also need a little bit more of your opinion. And we are very thankful that we've been funded by Duchenne Parent Project Netherlands, where we're trying to recruit a cohort of boys who've had vertebral fractures, been treated with bisphosphonate. Ask the young person, ask the family, what impact it has on your day-to-day life, but also what you think if we were to start treatment at a much earlier age before fractures. And I think that's kind of important to get that, okay? So, any questions at this point before I move on? Go on.
Can I ask what the disadvantages are?
So bisphosphonate therapy, the best way of giving bisphosphonate in growing children is with an intravenous infusion. It's 6 monthly. It requires you to come to hospital 6 monthly. Intravenous pokes are not easy in some boys with DMD, especially once they're a bit older. It does have some side effects, particularly with the first infusion. It's the best way I explained it is almost like a COVID vaccine reaction, a bit fluey, a bit fevery. Sometimes you can actually be sick and vomity. Just like the COVID vaccine, most are mild to moderate, but there are some which is severe. Okay? So if we're going to, taking aside how the service will cope, but if we're going to suggest every boy with Duchenne on steroids needs bisphosphonate, it might be that there are some of these boys who may not have fractures till 4 or 5 years down the line, and it's the extra burden on coming to hospital. So that's something that we just need to think about. I think it's a very good question. Any other question about bones, bisphosphonate? Yep, go on.
I've been on the bisphosphonates for, I think, maybe 2 and a bit years.
Yep.
I'm now 19. What's your opinion on continuing it into older years and in older years?
Very good question. Nobody really knows, and I'm actually trying to find this out so there's no evidence. Depending, my opinion, without knowing your case, I think if you've got spine fractures, there is the case to think about having some medicines, but maybe at a much less frequent interval. In adults about your age, the adult bone specialists tend to give the bisphosphonate infusion once a year or once every 2 years. Yeah. We don't really know what to do, and I'll come back to that in a little bit, which we might find out a little bit more. Shall we move on to the last bit of Leon's story? Okay. So Leon's been getting this bisphosphonate infusion for a couple of years. He is now happy. He's got no back pain. His bone density is improving. But between the age of 12 to 15, he's getting more miserable. He's trying to cope with his diagnosis of Duchenne, his muscles are getting weaker. There's a whole host of chaos of understanding stuff with Leon and in the family as well. He's also getting shorter. He's being bullied in school. You know, people think he's a 9-year-old. He's constantly patted on his head. And he's concerned that he's not developed like his peers. So he's worried about puberty. Now, and this is something that is very common in steroid-treated boys with DMD. He wants something to be done about it from the age of 12, but the doctors say that, hang on, you know, just wait till you're 14 or 15 and just, well, it may happen and, you know, we don't need to do anything about it. So the current international standards of care suggest that puberty needs to be monitored regularly, and testosterone to kickstart or take a young person through puberty should be given at the age of 14. It can be considered from the age of 12, but I think a lot of us, particularly endocrinologists like myself, would generally not start testosterone until the age of either 14 or older. And I think maybe in this particular group, there might be a case to consider lowering the age. Bearing in mind that on average, boys with no chronic health disease start puberty at the age of about 11, okay? So what have we been doing in Glasgow? We've been monitoring puberty very regularly. And in January 2022, we looked at our entire clinic database of all patients who have been seen in Glasgow since 2015. And all the patients who are 14 and above have been examined by myself, and there were 38 boys. And these were clinical examination and evaluation. We included 37 boys in these next couple of slides I'm going to show you. One I had to exclude, partly because, or mainly because he's got a second diagnosis. He's got a condition called neurofibromatosis as well, and neurofibromatosis can be associated with early puberty. So I just wanted to be clear so that it's just boys with DMD. So big headline is that in the entire cohort, 65% had delayed puberty, and that's at the last physical examination was almost 14 and 4 years, and there was a boy who's even as old as almost 17. And as I said, the average age of boys without any chronic ill health showing the first signs of puberty is 11. Then we wanted to see if there's any differences between those who had delayed puberty versus who had normal puberty. And just to make sure that the comparison is actually similar, we looked at all these characteristics at the age of 14 for the boys, okay? In those who had delayed puberty, pretty much universally, all of them were on steroids other than one boy, and they were all on daily steroids. In the group with normal puberty, only about 70% were on steroids, but half of them were on intermittent steroids. And of course, we had more people who were off steroids in the normal puberty group. Not surprisingly, because pretty much you see the impact of, we heard about the impact of steroids. In the delayed puberty group, most of them were still ambulant at the age 14, whereas only much less were ambulant at age 14. And similarly, you can see that whole mechanical ventilation and severe scoliosis needing surgery. But you can see that those who had delayed puberty had vertebral fractures. And what this is telling us is not that puberty is bad for your outcomes, but really these groups are not matched because you've got boys who are basically mostly all treated with steroids and also daily steroids, which we know works, but unfortunately comes with all this list of side effects that 37 or whatever is in the British National Formulary, if you ask, will be commoner in those on daily steroids, okay? And if we look at those who are on daily steroids in our group, 82% of them have delayed puberty. So what this tells me is, in fact, actually, if you're on daily steroids, your chances of having spontaneous puberty is much less. The numbers are quite small, but those who are on daily steroids who did have puberty were somehow, unfortunately, some of those late diagnoses who only started steroids around about the age of 9 or 10. So the duration of steroids is it's not significant statistically, but seems to be a bit shorter in this group. So daily steroids, very unlikely for puberty to start spontaneously. Intermittent, probably okay, but our numbers is too small for me to be completely conclusive. So what do I think? So I think that puberty is something that's very important that needs to be addressed for the mental health and quality of life for the young person. It, however, needs careful discussion and examination from an earlier stage. It then needs earlier treatment. What I have been doing is up to about 218. I generally start testosterone treatment close to the age of 14 or after. From about 2020, I've been lowering it because I've been seeing these data. They just, I wait and nothing much happens. And from now on, I've kind of been willing, well, not so much willing to, I've actually been initiating boys as close to the age of 12, which is actually part of the standards of care. It says that you can consider from 12. But the boy needs to be ready. The physical and emotional changes as part of puberty and testosterone treatment needs to be discussed with the young person, and that's important. So Michela has already talked through some of these stuff from GMDK UK. The thing that I actually really want to flag up is that it's very important when a boy comes for an endocrine assessment as part of assessment of puberty that one, hopefully people like Michela will actually mention the need for intimate examination with the young person, that the parent discusses that with the young person. Their leaflet, we hope, will actually trigger as some sort of a moot point for you to discuss that because it is an intimate examination. So this is what I think. I think in time, a slightly more proactive approach to managing steroid side effects in those who continue to be treated with steroids, particularly daily steroids, is something we need to think about. We need to find out a little bit more about the patient's preferences, and we are starting to do some of those things. And managing care requires research, but research in rare diseases does not really interest lots of large funding bodies. And I think what we have been fortunate is that working with patient groups with the condition, because I think sometimes gathering small experiences of some of our clinical management, a few centers, is actually very helpful for guiding future clinical management. And I think lunch should be about there. We might have a little bit of time for discussions, and maybe Michela and I could.
It's one question, two parts. So my son falls into your sort of demographic of starting at sort of late 12, 13 on testosterone. We're in Sheffield. But a year and a half or so later, it was felt that he had started to naturally produce testosterone and puberty was sort of taking a natural course, and so it was stopped. So what's your view about that sort of?
Sorry, I missed that. So he started testosterone.
So he started at sort of 12, 13, but then on later assessment, it was felt that he had started to sort of naturally progress into puberty, and therefore that was that.
Sure. I see that as well. What I can't tease out yet is that some clinicians, and I don't know Michela's practice, is that when you lose ambulation, so I think previously steroids is stopped, but some sites are lowering the dose of steroids at the time of loss of ambulation, which is usually around the age of 13 to 15. Okay.
Sorry, talk about testosterone.
No. I'm with that. It's steroid that hampers puberty. So I have seen some boys who seem to initiate puberty naturally on testosterone treatment, but some of it is because the steroid dose has been lowered. Okay. It is a question I can't answer yet. Majority will need testosterone to take them all through puberty. There are some who, like your son, and I have seen that also seem to start spontaneously on his own.
But the thing is that it's whether that's now plateaued and it's now
Correct.
off and whether
Correct.
we should reinitiate.
Maybe we're thinking that probably the thing is, each individual is different, and as much as you can have a rule of thumb, then change it. Important is if it goes naturally. Some of them, at least in Newcastle, we see that some of them go naturally to puberty, but actually never really kick off.
Yeah, that's kind of
And
where
then
I'm
it start to plateau and go down.
That's
It's
what
important
we're
that is continue the monitoring, because we have some that continue in testosterone for 2.5 years, stops because the levels were fine, but then they notice that a year later the levels will drop again.
Exactly, exactly. So I know Michela's endocrine colleague that I know very well, Dr. Wood, Claire Wood, has done some lovely studies, and my impression as well is that the majority, you do seem to take them through puberty with testosterone. Once you stop that at the end of adolescence, majority will be okay, but I have a few people who their testosterone levels are still in the boots, basically. Correct, exactly.
The second question was, are there any additional benefits of testosterone beyond just...
Exactly. So these boys will grow a little bit, okay? So it's not the major pubertal growth spurt like 20, 25 centimeters, probably about 4 to 5 centimeters. It matters to some of these boys, basically. It obviously changes their appearances in puberty. Claire Wood's and Michela's study from Newcastle and other people show that it certainly normalizes the amount of bone accrual. And the study from Newcastle, in small numbers, suggest that there may be some slight improvement in muscle MRI with testosterone treatment. It's not with functional outcome, but I guess the good thing is that it seems to not be worsening the muscle, which is what some people were concerned about. Michela and Newcastle team are very advanced in their thinking. Some neuromuscular clinicians have, and probably some still are still a little bit hesitant because there's all this worry that it damages the muscle, and it doesn't seem to be. So questions for either myself or Michela? Yeah, go on.
You said about the biphosphonate treatment obviously starting related to the vertebral fractures. Do you start it if there's multiple long bone fractures as well?
Yeah, good question. So the long bone, I think, again, this is something that we learn more and more. I think the standards of care actually does recommend that if you've got a long bone, low trauma fracture, that this should be initiated, okay? I must say that this is something that, and you could see that, so when I presented my data, some we haven't, partly because we've got a little bit more experience of how the extent of fractures, okay? Some patients were also just not referred. Sometimes the bisphosphonate infusion, it does seem to be helpful, and we now have more experience in data, but it is also a bit of an ask to get the families to come for intravenous pokes in 6 monthly and things like that. Unfortunately, we don't seem to have an equivalent like a cream or a tablet that's easily taken or just as effective. But yes, if it's a low trauma fracture, long bone fracture, low trauma long bone fracture is that if you are, so there's no major trauma, you're either walking or falling out of a wheelchair or just standing and you're falling and you fracture a bone, that's a low trauma fracture.
I think that is a little bit the difficulties, especially in children. Define is, children can fall and break their legs, and then it's a part of being a child. And I think that this has led sometimes to underestimate how often they actually break their legs. And we have several boys that have 4 or 5 fractures, and then it's only when you start to say it's 4 and 5 is then something that we need to consider. So I think that also that approach will change in the coming years, and will be much more conscious of the fact that it's true that children break, but actually having repeated long bone fractures, especially if I have a few that get crushed completely in a situation when they get everybody could have broke 3 legs probably, but if there is no rationale behind the fracture, I think that we would need to be a little bit more proactive.
Yep. So I guess the thing I want to mention as well is that, so we know about, a lot of us hear about the 2018 standards of care, but the first standards of care for Duchenne was actually 2010. In 2010, it talks about like you need to think about bones. It gives no recommendations of treatment at all. In 2018, it recommends the bisphosphonate threshold that I talked about. But basically, at the time of 2018, there was only 1 study of bisphosphonate in Duchenne. And at around the 2016, 2017, which is when the 2018 standards of care was being prepared, there was really only 1 study in 7 boys with Duchenne treated with bisphosphonate. Since then, there's about 7, 8 other studies, including 2 randomized control trials. So not that it's experimental at that time, and lots of doctors are probably using it, but it's just not been shared and published, and some of us are just a little bit hesitant. And I think what Michela is saying is that in time, in those treated with daily steroids, I think we will be a little bit more comfortable, a little bit more proactive. But like lots of stuff, and what Dr. Burke said earlier about cardiac protection and starting medicine, some of it also will be in discussion with the family, because it is a burden as well. Okay.
I think that we can I'm not denying the fact that we need to think about how do we address this within an NHS service. So it's different if I have a tablet or I have something that you can take at home. If you want to be very proactive, I mean, to say anybody with one long bone fracture should have is an admission to the hospital, is a bed that needs to be found. Doctor, the first injection, at least in several trusts, the first injection is an in-hospital injection, so you need to stay overnight. And the capacity, how do we manage this? How can we prioritize the cases that definitely need them and when the one that is for that? So, and you need to collect evidences in a way to support your case to say that is their recommendation, therefore need to be implemented.
So what I think over the next couple of, so you might find that your doctors are saying things that are a little bit more advanced or aggressive than the 2018 standards for care, and that's okay. Just like the cardiac things as well. Somebody asked, like, why not start, like, ACE inhibitor at diagnosis? Like Dr. Burke said, that's not wrong, and if that's what's discussed and that's what the doctor and patient are happy with, that's fine. But gathering a little bit of the patient's voice, a little bit more evidence, it may be in time we will find that, we will recommend osteoporosis treatment after, I don't know, 3, 4, 5 years of steroids, even if there's no fracture. I'm plucking it off my head, just to say, kind of thing.
Can I ask, if you aren't having the injections,
Yeah.
what would be, so would you be keen to stop them, or do you think it doesn't really bother you?
At the moment it doesn't really bother me because I feel that I get back pain generally, even like a couple of weeks after I've had the infusion. But sometimes I think that possibly there is more muscular pain or anything.
It becomes difficult once you're a bit older. So, and what I have found helpful with looking at these pictorial places of where back pain is, I think in an older boy with DMD and an adult, you get a lot of like lumbar back pain round about the buttock, and that's not fractures basically. And bisphosphonate obviously is not going to like help with the muscle fatigue, ache type positioning type pain, isn't it? In answer to your question, we don't really know what to do, but Action Duchenne and Muscular Dystrophy UK have actually provided some funding for a group of us, pediatric bone specialists and adult bone specialists, to come up with some kind of consensus of what we do with boys like yours, or men like yourself in the transition in adulthood, because the international standards of care mainly focuses on children. So we're not sure, but we might know in a couple of years' time. Is that time for lunch? I think it's more than. Okay, great.